Good evening, all the aspirants present here. So the debriefing session will be taken by Dr. Suvadeep Sen. Sir, you may take over. Thank you.
Yes, thank you so much. So, hello everybody, I am Dr. Suvadeep. I work in Apollo in Navi Mumbai. So today I have taken up mock examination for. So without much delay, let's start today's session. So let me just see that who were there at the time of the examination. Dr. Asif, I think he was there.
Yes, sir, have joined us too.
Okay, Dr. Dr. Raga.
Yes, sir.
Okay, sure. So anyway, all of you, whoever has given mock exam to me, so we have practiced one clinical case scenario and few case-based scenario. So we'll discuss the clinical case scenario, and I'm not giving anybody definite feedback, direct feedback, but what we can discuss today, we can discuss how to give answer to the particular questions in the exam, how to approach that kind of question. You can listen to the recording and then you can try and correct yourself whenever it is given, wherever it is possible. Okay, so we discussed about one case vignette about a 42-year-old male who was seen by bystanders as he intentionally jumped into an ice-covered lake on a cold December night when outdoor temperature was -6 degrees centigrade. He was recovered from the lake after an attempt for approximately 15 to 20 minutes. He was unresponsive. A bystander chest compression was initiated and call for nearby hospital was given. ER team arrived. You were the part of the ER team, and they initiated the CPR as per the ACLS protocol. Initial rhythm detected was asystole. CPR was continued, and the patient was brought to the hospital with ongoing CPR. He was called for help during resuscitation. So that was the case vignette that was been provided. With that, we built up the multiple questions. The first few questions are there. It's purely on resuscitation of this kind of patient. So what are the practical challenges in the resuscitation of the patient? How will you overcome the challenges? What are the salient points in the resuscitation protocol in hypothermic patients? And what are the prognostic factors in determining overall outcome in a post-drowning hypothermic out of hospital cardiac arrest?
Sir, please can you again repeat the first slide?
Repeat the first slide. Okay. So first in the first slide we talked about a one case vignette. Somebody got drowned in a lake, and the temperature was hypothermic. So she was brought by somebody, and then we initiated the resuscitation protocol. The question was what are the practical challenges in the resuscitation of this patient? So in the EDIC kind of exam, so which is
not clear, sir.
Which is an European diploma exam. So we'll expect this kind of challenging questions, and where you are required to know the CPR protocol in depth.
Voice is not okay. Voice is not clear at all. Voice is not clear.
Is it for everybody or it is for someone?
Mohammed Raga, please do check your connections.
Yeah.
The voice is audible.
Voice is audible. No? If it is for one particular doctor, please check your internet connection once, because I understand. Or you will get a recording. Most probably, you can listen to that thing later as well. And you can send me your queries if you have any in the later part as well. So now coming to the discussion of this kind of patients. Now, what are the practical challenges? So I have taken example 3 of yours, you candidate. So whomever have, I think one candidate has given a very good response to all of the questions. But the thing that we lacked over here is that the answers are not very to the point, and the brief and the to the point that are expected to have. So now, if somebody asks what are the practical challenges in resuscitation of the patient, the three practical challenges. Number one, uh, first is it is an out of hospital cardiac arrest. That is one challenge. Second, it is a resuscitation after drowning. That is second challenge. And third thing, it is resuscitation in a patient who is hypothermic. So there are the three challenges that we are anticipating during resuscitation. So these three challenges you need to address separately. So how will you overcome? So these three challenges you need to know that how will you address these three separate challenges in this particular patient. Now, uh, 1, 2, 3 is a kind of almost same question. So it's a part of the same question. Now, what are the challenges that we anticipate in somebody in during resuscitation in a patient who is drowning? Now, whenever we talk about resuscitation on the CPR protocol, we talk about A, B, C, D, E. So that is a kind of very practical way to talk about in any exam or in any practical steps. What are the airway-related problem over here? Somebody who has been drowned, we can expect a lot airway obstruction from water, mud, soil, and all these things. Patient can go in can be in laryngospasm from the downing, which is because of this vagal response. We can have a cervical spine injury in that this kind of patient. So we need to provide protection for the cervical spine. And as most of the patients develop cardiac arrest because of this respiratory arrest, it is better to intubate these patients early with a C-spine protection. So these are the airway related problems. We need to clear the airway initially. We need to try for clearing the airway, do the suctioning, and then we need to secure the airway as soon as possible. That is the airway related problem. And what is breathing related problem? Going to the B part. Breathing means so these patients have a respiratory arrest. So most of the time, somebody who has developed respiratory arrest followed by cardiac arrest, it is imperative to start the ventilation the earliest. So we need to intubate this patient, secure the airway, and put them on a positive pressure ventilation. Now, most of the patients, a lot of patients that drowning, they develop a non-cardiogenic pulmonary edema. Their lungs are filled with a lot of water. So initially, we need to give 100% of oxygen. We need to continue. We need to talk about lung protective ventilation. We need to talk about when to prevent barotrauma. But initially, we need to do an ambu ventilation with 100% of oxygen. So that is how we adjust the breathing. Now coming to the circulation. Circulation, this patient is drowned, so we need to start the effective chest compression as early as possible with 30:2 or whatever the ratio or 2 minutes. Yeah, that's highly effective chest compression. So that needs to be initiated as early as possible. Along with that, we talk about the D and E. We see that whether there is some other injuries as well, like this patient might be having some associated injuries like long bone injuries or something like that. Some might be bleeding. So those things need to be taken care of, and we need to prevent the exposure for like hypothermia prevention. So they are all comes in a kind of resuscitation protocol in somebody with a drowning. So that is this is number one. Now second challenge is that which is related to the hypothermia, because the patient was not only drowned, he was drowned in a cold temperature. The temperature was less below minus temperature. So what are the challenges that we anticipate in reviving somebody who is hypothermic? First thing, because of their hypothermia, sometimes hypothermia is a mimicker of the brain death. Most of the time, most important aspect in the resuscitation in somebody who is hypothermic is that do not prematurely stop CPR. It is imperative to improve the core temperature till the core temperature goes goes above 32 degrees centigrade. We should continue CPR. The chest compression needs to be continued. That is the most important and the primary thing. And along with that, we should start actively warming the patient with anything like we should give warm humidified oxygen. We should we should provide warm blanket. We should provide this. We can use this Biaraga like post air, and we can use some warm fluid in this kind of patient. So there are a lot of ways to warm this patient, but we need to. The idea is to warm the patient. Second challenge is what is the defibrillation protocol? What is the difference in the defibrillation protocol in hypothermic patients? Initially, somebody who suppose the initial rhythm is pulseless VT or VFib, then we can give 3 consecutive shocks as per the protocol. But if the 3 consecutive shocks are not effective, then we should wait for subsequent shocks till the core temperature goes more than 32 degrees centigrade. Because what we know that when the core temperature is less than 32 degrees centigrade, defibrillations are unlikely to help. So initial 3 shocks at the 2-minute intervals are okay, but beyond that, subsequent shocks are usually futile. So unless the core body temperature goes more than 32 degrees centigrade, we should not attempt, or we should not keep on giving multiple shocks. So that is the one important change that we have in the ACLS protocol of resuscitation in hypothermic patients. And what is another caveat we have is the dosing and the drugs. So usually all this adrenaline or resuscitation drugs that we give, they are also not very much effective in presence of hypothermia. So idea over here is by any means we need to improve the core body temperature beyond 32 degrees centigrade, and after that we should start defibrillating them and start giving them start administering the resuscitation medicine. And one important caveat over here is that because we keep on administering medicine, and in presence of hypothermia, the drug metabolisms are inhibited. So whenever these patients are warmed, the patient might develop the accumulation of those drugs and the toxicity from that medicine. So we need to keep those things in mind. And one important thing that we should talk about in all such kind of patients is that in somebody who is hypothermic, where there is a continuous effort of ongoing CPR is going on, then ECMO CPR is one important thing that we should also think of, because first of all, ECMO will help in improving the core body temperature as well, and at the simultaneously it gives you time. Most of the time, the hypothermia acts as a brain protection, so we don't need to mind. So we just need to start improving the body temperature. Just 1 minute. Okay, am I clear? Is anybody any question? Please, you can just put in the chat box, or you can let me know. And what is the third important challenge over here is it is a out of hospital cardiac arrest. Now, out of hospital cardiac arrest technically is much more difficult and prognostically much more inferior than the in hospital cardiac arrest. You all know, because the overall survival is less than 10%. Why is it so? Because out of hospital cardiac arrest poses difficulty in a lot of ways. Like suppose we initially bystander CPR is started. So first of all, there might be a delay in recognition of the cardiac arrest condition, and delay in initiation of CPR, and delay in effective CPR. Somebody, most of the time, bystander starts the CPR technique might be suboptimal. So the patient that might pose a difficulty in overall outcome. And the two techniques that we all know, that sometimes we decide to stay and play technique, like we just start CPR, effective CPR in the place of the out of hospital place only, or we scoop up run technique, or we bring the patients as soon as possible to the nearest hospital and start giving effective CPR. So inconsistent CPR technique and delay in recognition of the cardiac arrest condition, they play a vital role in determining the overall outcome in out of hospital cardiac arrest. That we need to keep in mind. So it's not only delay in CPR technique, delay in securing airway, delay in securing IV, all these things matters in out of hospital cardiac arrest. And one important thing over there for bystander CPR in out of hospital setting is the checking the scene safety, because most of the time it is very important to check for the scene safety in this kind of setting. Okay, so are you getting my point? So anybody has, let's see whether it will okay. If anybody is having questions, please let me know. Okay, all clear. So that should we go move to the next set of questions? Can you please, one of you can give thumbs up so that I can understand, so that I'm audible or not?
Yes, sir. You can proceed.
Okay. So we'll go to the next phase of the question, next state of the question. So for this patient, RST was achieved after 65 minutes of CPR. The patient was intubated and ventilated during resuscitation. After ROS, the patient was shifted to the ICU. He was comatose but became hemodynamically stable with time, and he was kept on sedation. Okay. So what will be the post-resuscitation care in the initial 72 hours? What all investigations need to be sent, and what all plan of treatment for the initial? So again, this is the basic post-resuscitation care for initial 72 hours. Again, we need to divide our answers in terms of airway, breathing, and circulation. How do we give the respiratory support? Like we need to talk about lung protective ventilation, the drowning setting. So patient might be at risk of non-cardiogenic pulmonary edema. So they might develop ARDS. So we need to talk about lung protective ventilation. We need to talk about the blood pressure maintenance, prevention of the barrel trauma, giving the optimal T. All these things we need to talk about. The patient, then the hemodynamic control, giving how much fluid, the goal-directed fluid therapy with a point of care ultrasound technique. All these things we need to talk about in this. In initial investigations, again, one important investigations that we need to keep in mind in this kind of scenario is checking the electrolytes. Sometimes it might be saltwater drowning, it can be sweet water drowning. So the patient might be at risk of developing hyponatremia or hypernatremia. Those things needs to be talked about over here. Then we need to talk about the sugar control over here, and regarding the investigation, one important thing I would tell you to avoid is that brain imaging. You can talk about the brain imaging initially, because to rule out any intracranial bleed. But if any intracranial bleed is not there, then subsequent imaging or MRI brain for prognostication of hypoxic ischemic encephalopathy is usually conducted after 4th to 5th day. So that you should keep in mind. Do not talk about the MRI initially, because I think one of you has spoken about the MRI initially, which doesn't make any sense in this post-resuscitation care. So different, because there's very small things, but examiner will understand that whether you actually do it or not. So so it's a very basic set of questions, but you need to divide your answers in a more organized way. So we have been given some day 1 labs, hemoglobin, WBC, creatinine. There's some set of the labs are given. Now going forward, the patient remains. Let's see in chat.
Can you hear me? Can anybody respond?
Suvadeep, it is audible.
Yes,
You
sir.
continue.
Clear.
Sure. Okay, so far everything is clear. Do you have any question so far? Because now we'll go in a completely different trajectory. Okay. So initial part was completely on the ACLS protocol in a hypothermic patients and in the drowning setting. So that is the initial part was there. Now we'll go in a completely different trajectory. Okay. So patient remained on ventilator and comatose. After 3 days, GCS is E1 VTM1. On day 3, he suddenly became hypotensive, required 2 inotropes to maintain the blood pressure, pupil blown bilaterally and non-reacting. Now, what is the current clinical evolution? Anybody can tell me what is the current clinical evolution? How do we explain this current condition?
The sepsis with septic shock with AKI stage 1 and
Yes. So that is the thing that everybody need to read the clinical scenario. So this patient remained comatose after 3 days and now suddenly become hypotensive, and his pupil bilaterally dilated and non-reacting. What do you think the patient will be having? The patient is becoming brain dead. So we are probably thinking of we should think about possible brain dead scenario. So I think one of you have told about the sepsis and all these things, but you will not think of sepsis over here. Why? Because it has been very clear cut. Patient remained comatose, sudden hypotension, and now pupil is dilated, non-reacting. So we should think about the possible brain death scenario. So that is the answer of question 6. Now the trajectory entirely changed to a particular direction. So how will you evaluate the potential brain death patient? How will you diagnose the brain death state? So next set of questions will completely on the how do a brain death state testing? How do I do an apnea test? What are the common confounders of the apnea test? What are the ancillary tests? How will you communicate these patients to the relative? Can this patient be considered as an organ donation? So next few slides we'll talk about how to identify a brain death patients. So how do we do that? So first thing, we need to document a catastrophic neurological diagnosis which is compatible to the irreversible cessation of brainstem. What is a brain death state? Brain death state means that there is a irreversible and complete loss of brainstem function, which is irreversible. Irreversible and catastrophic. They're the two important terms that everybody needs to keep in mind. That whenever we talk about the brain death state, there has to be a compatible neurological condition. Does this condition has a compatible neurological condition? Yes, probably yes. And whether we need to identify with the brain death test whether this condition is reversible or the irreversible. So first we need to exclude the condition that are the confounding that can confound the clinical examinations. I'll come to that part. And we should exclude a disease that can mimic the brain death state by neurological criteria. So we need to exclude the confounders and we need to exclude the mimickers. And then we need to document the irreversibility with 3 different things. One is coma, second thing brainstem areflexia, and third thing positive apnea test. These 3 things needs to be told whenever somebody is talking about the brain death testing. Coma means there is it has already been given. The patient's GCS is E1, VT, M1. That means that it has already been told that the patient is comatose. So how do we define coma? There is an absent evidence of arousal or awareness to the maximal external stimulus, including noxious visual, auditory, tactile stimulation. So there is an absent brain-mediated motor response to the noxious stimulation to the limbs. So that is what how we define the coma. Next thing is that brainstem reflection. What do we check? We check for the pupil. The pupils are bilaterally fixed and mid-size or non-reacting or dilated. We can demonstrate the corneal reflex, which should be absent. Oculocephalic reflex and the oculovestibular reflex are not applicable in this setting whenever the C-spine is not cleared. So we'll not talk about the oculocephalic and the oculovestibular reflex over here. And there will be absent facial movement to the noxious stimulus, absent gag reflex to the pharyngeal stimulation, and absent cough reflex to the deep tracheal suctioning. So these things needs to be absent before proceeding to the final test, which is called apnea test. And if all these things are, even after all these things, which is they are not confirmatory, then we should proceed for the ancillary test to confirm the brain death condition. So how do we identify brain death condition? We document coma, brainstem areflexia, and positive apnea test. Now coming to the conditions. What are the situations that need to be corrected before initiation of the brain death testing? First thing, we should think about the CNS depressing drugs. Like this patient was initially on sedatives. It has been mentioned about that. That is why it is very important to talk about read the scenario. So it was mentioned the initial 3 days he was on sedative infusions. So first we need to stop the sedation, and we need to give at least 5 half-lives before starting the brainstem BSD testing. And in presence of altered renal and the hepatic dysfunction, altered or renal or hepatic function, or in presence of hypothermia, then we need to give a longer time. So that is number one. In such selected cases, we need to check the drug level. In presence of the muscle relaxant, continuous infusion of the muscle relaxant, we should document of TOF twitches, whether the TOF twitches are coming back or not. And we need to do a toxicology screening for all patients before starting the BSD testing. For alcohol intoxication, it needs to be documented the alcohol level is less than 80 milligram per dl. We should exclude severe electrolyte, metabolic, and the acid-base imbalance. The temperature should be, core body temperature should be more than 36 degrees centigrade before starting the brainstem testing, BSD testing. And if somebody who is hypothermic, we should wait for at least 24 hours before after warming of 36 degrees centigrade. He should not have severe hypoglycemia or hyperglycemia, and systolic blood pressure should be more than 100 millimeter of mercury. So these things needs to be ensured before initiating a BSD testing. What are the BND mimickers? If somebody on a locked-in syndrome, fulminant GBS, botulism, neurotoxic snake bite, severe hypophosphatemia, severe hypothermia. So there are certain branded mimickers that we should remember and state in the exam. Now talking about the apnea test, which is the most important part of these questions. Whenever we apnea test is one thing all intensivists are supposed to know. So we always emphasize more on apnea testing, and we always ask each and every minute details about apnea testing. Whenever we do an apnea test, first thing we talk about the preparation. How do we prepare the patients before apnea testing? First thing in the preparation is the pre-oxygenate for 10 minutes with 100% oxygen, and we should aim for PO2 for at least more beyond 200 millimeter of mercury. We should adjust the ventilator to achieve a normal PCO2 of 35 to 45 and preferably normal pH. We should adjust the fluid and vessel pressures to keep the hemodynamics under control. We should give a proper exposure of the chest and abdomen so that we can observe the patients for the movement and the breathing response. Preferably an invasive arterial line should be there, but it is not mandatory. It can be done without arterial line as well, but we prefer to have an A line in situ. We should have a continuous ECG and the pulse oximetry monitoring, a point of care ABG machine, and after pre-oxygenation, we should do an ABG to document PCO2 at the end of pre-oxygenation. So that is the preparation part. Then after adequate pre-oxygenation and the preparation, the ventilator is disconnected and apneic oxygenation is maintained for 8 to 10 minutes. There are two techniques of apneic oxygenation. Either we can do for the tracheal insufflation technique, where the oxygen is delivered at the level of the carina at 6 liters per minute. Usually avoid to give oxygen at higher rate, like if you give a 10 liter, 12 liter of oxygen per minute, then the carbon dioxide might not accumulate in a desired way. So you might require a higher time for carbon dioxide accumulation. Or the second technique is the CPAP technique, which is using 100% of oxygen with the same PEEP which the patient was requiring before the apnea test. That is that there are two techniques. Either we go by the tracheal insufflation technique, or we go via continuous CPAP technique. What we monitor during apnea test? We monitor the hemodynamic status. We monitor the oxygenation status with the pulse oximeter. We do a continuous ECG on the monitor. We should observe the patient chest and abdomen for any breathing response, visually, and any other for any kind of breathing response needs to be observed. And along with the breathing response, we should observe movement for any other body parts like limb or legs or abdomen. Any movement we need to observe. And if suppose we are using a bench circuit, sometimes we use a bench circuit for apnea testing, then we should observe for the respiratory effort in the bench circuit or even in a ventilator by watching the. And if using a ventilator in CPAP mode, we can use the flow waveform to understand whether the patient has initiated breathe or not. So these things we need to monitor. What we do next, we do a serial ABG after the end of 8 to 10 minutes. We take a second ABG While the second ABG is pending, apnea test is usually continued and apnea is repeated. When do we say that the apnea test is positive? If there is no respiratory effort during the entire duration of the apnea test and post-test PCO2 is more than 60 millimeter mercury or 20 millimeter mercury above the patient's pre-apnea test baseline, and the arterial pH is less than 7.3, the patient is known to be, apnea test is considered to be positive. If the PCO2 is more than 60, but there is a patient-initiated breath is observed, then the apnea test is not positive. So that is one important thing is we need to keep in mind. Now, it is very important to remember the apnea test needs to be aborted immediately if the patient takes a spontaneous breathing, or the patient develops severe hypotension, or patient develops unstable arrhythmia, or patient develops significant desaturation, or the saturation is less than 85%. For all practical purpose, before aborting, usually what we do, we usually take one ABG to understand whether the PCO2 has built up beyond 60 millimeter mercury or not. We should always keep in mind in patients with a high cervical cord injury or primary medullary injury, apnea test may be falsely positive and should be confirmed with an ancillary test. That is one caveat that we should always remember. Any questions on apnea test? There are certain metabolic derangement we all again need to know, which can confound the result of the apnea test. So before apnea test, that needs to be corrected. Serum sodium should be always below, preferably below as normal as possible. So it should be more than 132. So usually try to keep the serum sodium less than 150 for all practical purpose before apnea test. Potassium should be normal, magnesium should be normal, calcium should be normal, blood sugar should be, there should not be any hypoglycemia. So these, they're the certain things that we need to see before apnea testing. So this table has been taken from the this American Association of Neurology guideline of 2023. Okay, so any questions on the apnea testing and so far? Anybody? No. Okay, so coming to the
Can you just explain why oculovestibular and oculocephalic is not done?
Tell me, sorry, why?
Why oculovestibular reflex and oculocochlear reflex?
So in this patient, we do not know what is the cervical spine status, so we do not know. So for all practical purpose, oculocephalic reflex is contraindicated when there is a suspected cervical spine fracture.
Okay.
Okay.
Okay. If we have ruled out, better not to utter is what you.
It is, if we ruled out, so better not to utter only, because oculocephalic and the oculovestibular reflex are not very commonly performed as a routine test for before apnea testing. So there are other, we can do a corneal reflex, we can see the pupillary reflex, then we can see the carinal reflex, we can see the pharyngeal reflex. They are more than sufficient in most of the cases, but for all practical purpose, it is better to say, suppose the cervical spine, there are centers where they can do a cold caloric testing, but usually they are not a routinely done practice in most for all practical purpose in most of the centers. Okay. So should we proceed?
Yes, sir.
Yeah. So coming to the ancillary test, again the questions are very clear. What are the ancillary tests? The examiners will expect you to know the certain what are the names. They might not go into detail of those things, but they might expect you to know what are the ancillary tests that we perform. Like what are the ancillary tests that we perform? We do a EEG or evoked potential based tests like visual evoked potential, or auditory evoked potential, or somatosensory evoked potential. We test for the cerebral perfusion with either digital subtraction angiography or transcranial Doppler, or CT angiography or MR angiography. If there is a provision of doing a SPECT, we can do a SPECT as well, or we can see the metabolic function of the brain by perfusion scintigraphy or even the SPECT. SPECT, if it is available, then it is one good choice of having an ancillary test. Okay. Is there any questions so far? Should we proceed?
Yes, sir.
Yeah. Now coming to the family opts for the organ donation. How will you manage the patient till organ donation? And there's a one question was there: if the patient is found to be polyuric, what might be the potential causes of polyuria in somebody who is brain dead patient? Okay. So again, I'm not going into details over here. So organ support in case of brain death state. Again, the answer should be categorized in or organized in different organ support. Like again, we should organize our answer like hemodynamic support, hemodynamic monitoring and support, respiratory dysfunction and the challenges and the respiratory support, endocrine, metabolic dysregulation and the support of that part, and the temperature management and the hormonal management. So they are the ways that usually those things are, you need to tell that. Hemodynamic monitoring, then what will you say? We need to maintain we should aim for the normal volemia, we should give the fluid resuscitation as per the volume guided technique or echocardiography. We can use the vasopressors as per requirement. Vasopressors are often used. The noradrenaline, norepinephrine can be used. The choice of the fluid, it depends on the fluid status of the patient and the electrolyte status. Suppose somebody is hypernatremic, then we tend to use hypotonic fluid. Suppose somebody is high sodium level is normal, then we use the balanced salt solution. Respiratory dysfunction, we do for all practical purpose, we practice the low tidal or lung protective ventilations with optimal PEEP technique. These patients are more prone to develop various respiratory complications, lung collapse, the barotrauma, or ARDS kind of situation. So we need to continue the lung protective ventilations. For metabolic dysregulations, we need to maintain the normoglycemia. Then we talk about the hormonal therapy in terms of the vasopressin therapy or desmopressin whenever there is the sodiums are high. We need to talk about the supplementation of the steroid, supplementation of thyroid, supplementation of the insulin. All those things needs to be talked in a systematic way. Electrolyte is one important thing for all practical purpose for any patients who are brain dead and opting for the organ donations. It is very important to keep the sodium level towards normal as normal as possible, because if the sodium level is beyond 150, that is a independent predictor of graft loss in somebody who is receiving that graft. So that we need to keep in mind. So for all practical purpose, the electrolyte level should be under control. And the temperature management, that this patient temperature needs to be maintained. The feeding, we may continue the feeding for this kind of patients, or if the sodium is very high, our patient is going for the going to the OR soon, then we can hold the feeding. DVT prophylaxis needs to be continued. All these things needs to be told in a systematic way. Okay, any questions in this in the organ management in the patients with the brain death state? We can talk about it. But most important thing is to organize your answers in a systematic fashion. Coming to the cause of the polyuria, which is encountered in patients with the brain death state, it can be because of the central diabetes insipidus, which is the commonest cause. But before that, we should see the patient might have received mannitol or something like that, which can cause osmotic diuretics, or the patients might have hyperglycemia, which can cause osmotic diuretics. Patient might have received some furosemide or something, which can also cause polyuria. Somebody who is hypothermic, that can cause hypothermia-induced diuresis, and we can have a combination of all the in these patients. Okay, so that ends our CCS. Any question on CCS? Otherwise, we'll go to the CBS. Okay, so the CCS was first part on the resuscitation protocol, and the second part completely on the brainstem determinations and the organ management. Okay, we'll go to the CBS. If there is no further questions, we'll go to the CBS. Oh, so we're quite late, so we'll go a little faster in the CBS. Most of have given the CBS right. So again, we can see that there is a 26-year-old male admitted with the RTA, hemodynamically unstable. So what is the diagnosis over here? Just 1 minute. Yes. So what is the diagnosis over here? So there is a traumatic hemothorax along with, can you hear me?
Yes.
Oh, sorry, I got muted. So there is a traumatic hemothorax. You can have a small apical pneumothorax as well with a multiple rib fracture. Okay, and what will be your plan of management? Plan of management is to resuscitate this patient with a large bore. We should talk about large bore IV cannula. We should give isotonic fluid replacement, if required, blood and blood product replacement, and all these things we need to talk about for resuscitation of trauma. Basically, you need to talk about the how will you resuscitate that trauma patients in pneumothorax. Okay. So again, organize your talk for with airway, breathing, circulations, and like that. Going next, a 45-year-old gentleman, rotary extent, low GCS, breathless, hypoxic, when arrival to hospital, emergency intubation to the ER, CT bed. So what is CT showing? CT is showing diffuse SH. How to grade the severity? Again, so we should know that what is the WFS grade and Hunt's grading scale of the subarachnoid hemorrhage. And with the CT, how do we do? We do a Fisher grading. What is the CT grading of that this person? So there is we can see there's a diffuse SH with the intraventricular hemorrhage and the basal cistern is occupied. So it is a Fisher grade 4. Okay. Coming to the X-ray of the same patient. X-ray of the same patient. What we see over here? So it is a right endobronchial intubations. Do not talk about mucus plug and all these things because you can clearly see that the intubation, the endotracheal tube is going into the right mainstem bronchus, causing right upper lobe collapse. Okay, so what is your plan? We need to just take out the endotracheal tube by under supervision, and we should confirm the position by X-ray. Okay. What is this? Anybody? Let's make it a little interactive.
Bilateral pulmonary embolism.
Yes, good. It's a bilateral path. How will you decide the plan of treatment?
Risk stratification, whether
Plan of
it's massive,
treatment
submassive.
is decided on the basis
According
of
to risk probability.
yes. So patient's hemodynamic status and the patient's whether and whether the patient is a high risk of developing hemodynamic compromise or not. So this is a ESC guideline. So how do we determine the treatment? If there is a hemodynamic instability or patient is having a high risk or high intermediate category of deteriorations, then the idea is to thrombolize the patient. If the patient is a low risk category, what we give? We start therapeutic anticoagulation. Okay. What is this? A young lady admitted with a fever for 2 days with seizure and right upper leg weakness. What is the diagnosis? Anybody? What is the diagnosis? Somebody with a fever and altered sensorium. What do you think?
Encephalitis. Encephalitis.
Encephalitis.
Yes, encephalitis. So it is. So you can see that T2 hyperintensity in the temporal lobe. It is typical site for herpes encephalitis. So it's a herpes. And how to manage? First, we will do a lumbar puncture, confirm the diagnosis, and we will give acyclovir in a encephalitis or meningitic dose. What is this? This is a flow volume loop where the expiratory curve has not reached to the inspiratory curve. So what does it mean? It means leak. Very good. What action? We'll try to find where is the leak and then correct it. Now, what mode of ventilation is this? It is a volume control ventilation. What is the respiratory problem over here? What do you think the respiratory problem over here? Tell me, anybody?
Is there white
High peak
pressures?
pressure.
Are high.
High peak pressures.
High?
High peak and plateau pressures.
High plateau
Peak and
pressures.
plateau pressure. So what
Peak
do you
and
think the
plateau.
problem over here? What do you think the problem? This is a very common thing, and examiner will expect you to know about this.
Short and spirited, right?
Huh?
Pneumothorax.
Huh?
Thorax
No.
entity.
No. So what is the problem
Five.
over here? So here the blood pressure is high. So we should always see what is the compliance? What is the compliance of this patient? How to calculate the compliance in a ventilator? Tidal volume divided by blood pressure minus P. So what is the
P.
compliance over here? 270 divided by how much? 27. So almost compliance is 10. So that what does it mean? The patient is
ARDS.
having stiff lung. So we are dealing with ARDS. So what is the respiratory problem over here? CRDS. Mostly. What interventions we will take? What is the basic defect in this ventilator setting? The PEEP is low. So we need to optimize the PEEP. So first thing, what will be intervention? We will optimize the PEEP as per the patient's requirement. So we'll do a PEEP if I have to try titrations. Okay? Anybody any? So this is a very basic question. So everybody please you should be able to answer. So what is the mode of ventilation? Is the CPAP with pressure support. What is the problem over here? Is the ineffective triggering. How to correct? We change the trigger setting and we'll try to identify. What is the problem over here? So the patient has come to the ER with a crushing chest pain. CPR started for the ACLS protocol. Now the ETCO2. Now for all practical purpose during all resuscitation, it is mandatory to have a ETCO2. Why ETCO2 is required? Because ETCO2 tells you that what is the quality of CPR. Now, if the ETCO2 is less than 10 during a CPR, that means you need to improve on your CPR quality, chest compression quality. Whenever there is an abrupt rise in ETCO2, that means it indicates the return of spontaneous circulation. Okay. Now, what is this? AKI post cardiac surgery. Again, everybody should be able to answer. So there is it is almost like a sine wave pattern, almost like a tall T wave, almost like a hyperkalemia. How to manage? Please talk about the hyperkalemia management. 56-year-old male, sudden crushing chest pain, perspiration, cool extremity. What is the problem over here?
Inferior MI with right.
Tell me. It is a
inferior MI with right.
Yes, ST elevation in 2-3 AVF along with the V1, V2. So what do we think? It is a RV infarction. So ST elevation in whenever there is an ST segment elevation, lead 3 is more than lead 2, and ST segment elevation in V1, it tells us it is a RV infarction. Okay, how will you manage this patient? We will immediately plan for revascularization, mostly by shifting the patient to the cath lab. If it is not available, then we need to do a thrombolysis. Okay. This is everybody has told, that is good. Somebody the B-cell lymphoma received R-CHOP. What is the problem? Patient has developed post chemotherapy, renal function has worsened. Patient has developed AKI and hyperkalemia. What is the problem over here?
Tumor syndrome.
Tumor. How to prevent tumor syndrome?
Hydration before the chemotherapy.
Hydration, very important. Hydration. I think one doctor has not talked about hydration, talked about allopurinol. Please do not talk about allopurinol. Talked about hydration only before giving the chemotherapy agents. Coming to the one more vignette. Sjogren syndrome. Just read this thing. So fatigue, poor appetite, vomiting. What do you feel is the problem over here? Anybody?
Second failure.
Patient is having
Adrenal failure.
acid-based problem over here. Metabolic.
Non-NCAP metabolic acidosis.
Normal and non-NCAP metabolic acidosis. Very good.
Hypothyroidism.
So question was what? Acid-base balance. Non-NCAP metabolic acidosis. What is the next best test for the diagnosis? How will you diagnose? What will be your next step to diagnose? What is the cause of this metabolic acidosis?
Addisonian crisis.
Huh?
Addisonian crisis.
Addisonian crisis causes metabolic acidosis. That is true. But usually the potassium will be high, not low. Whenever there is a low cortisol, the potassium will be high. So it is not Addisonian crisis. What is the cause over here? Huh? Tell me.
Renal tubular acidosis.
So how do I, sorry. So what is the commonest cause of normal non-NCAP metabolic acidosis? Either it can be because of this vomiting,
renal tubular acidosis,
or renal tubular acidosis. How will you differentiate between that two? We will do a urinary non-NCAP. We will do a urinary non-NCAP. So what is the next base step? We will do a check for the urinary non-NCAP. We did a urine electrolyte over there. Now what is your diagnosis? So we do the urinary non-NCAP. Now it comes in a
urine pH 6.5.
Yes.
Renal tubular acidosis. Distal renal tubular acidosis.
It's a renal tubular acidosis. You can see the renal calcifications. Okay, it's a distal renal tubular acidosis from Sjogren syndrome. Now, patient with an ANF on CRRT, on ventilator, effluent dose is 3 liters per hour. On citrate anticoagulation, citrate dose has been given. Now, he has become suddenly hemodynamic instability with bradycardia with a QT prolongation. What do you think the problem is over here? What do you think the problem over here? Citrate.
hypocalcemia due to the citrate toxicity.
Citrate toxicity, very good. So how do you manage? How do you manage the citrate toxicity? We stop the citrate anticoagulation and increase dialysate to remove extra citrate from the system. Okay. What is this? 16-year-old boy came to the history of chronic cough, fever. What do you think about the ECG?
Dextrocardia.
First thing, please do not talk about dextrocardia. First, you will tell that I will check for the limb lead placement. If limb lead placements are proper, then we will think of dextrocardia. Okay. Always check for whether there is a limb lead reversals there or not. Okay. Any questions? I think with these things we will end. Any question? Anybody? Before we end today's session. If nobody has any question, then we'll end. Fatma ji?
Yes, sir. So we shall conclude this session.
Can we conclude the session? Yes.
Yes,
Thank
sir.
you,
Thank
everybody,
you
and
all.
all the very best for your upcoming exam. Thank you all.
Thank you, sir.